Hello. I wanted to talk today about our paper, which is recently accepted in Journal of Psychiatry and Mental Health. So, an author actually published last July about how it is difficult to translate a confirmed biomarker in traditionally conservative psychiatry. And I strongly agree with what he says, that changing clinical guidelines in traditionally biomarker-aversive field of psychiatry is not an easy step. Indeed. We wanted to add on the biomarkers, biochemical biomarkers that he was writing about, because we are actually dealing with biomarkers of depression and other psychiatric conditions extracted from electrophysiological signals. So, to cut things short, we really appeal to psychiatrists and other medical professionals who are working with patients who are suffering from depression and other mood disorders to really address some cardiovascular risks which are very important and unaddressed in current clinical practice, because it is possible in very easy, real-time, low-cost way to detect that. I will mention just some of the work that we have done, and not only our group, there are several other groups worldwide who are working on that kind of detection of depression. First of all, if you record electroencephalogram of a person who is suffering from depression, which is very well based in other literature why it is possible in neurophysiological sense, it is possible first to confirm whether a person really has depression or there is some other things that are mimicking that clinical picture. Why it is important? Because many people are taking antidepressants, which are all drugs with serious side effects. Basically, the reason for that is that practically many European countries, every family doctor can prescribe antidepressant medication to a patient simply based on his observation that he or she has a depression without further neurophysiological examination. Second, based on the same electrical signal that your brain is generating, so-called electroencephalogram EEG for short, it is possible to see which subtype of depression a person has, whether it is melancholic depression or non-melancholic depression, because that requires completely different approach to treatment. And if they use that kind of detection, clinicians could very early know how to proceed. So decision-making support in that sense. Then if we focus on EEG also, it is possible to discern whether a certain therapy works on a person, which is in perfect sense personalized medicine. You can prevent a patient to take a medication which is not working on him. You can also predict whether the person is a good candidate for any form of electromagnetic stimulation which helps in depression, like, for example, transcranial direct stimulation or even electroconvulsive therapy or transcranial direct stimulation, which can be done ambulatory or even at home. The second part of our proposal is to address increased risk of cardiovascular disease, which usually is mortality risk in patients who are diagnosed with depression. I'm not saying that every person who develops depression has cardiovascular disease, but we know from the literature and from the tons of research which is already published in the last 30 years that there is a confirmed neurophysiological connection between depression and variability heart rate. People who are suffering from depression show that they have aberrated heart dynamics, which is most probably in connection with the vagus nerve dynamics, and we call that corticovagal control, because vagus nerve in one of the branches is actually controlling the dynamic of heart and breathing. Separate branches, sorry. People who are clinically depressed exhibit lower heart rate variability and higher beats per minute in comparison to controls. It is confirmed in many publications, and we are just about to publish the study about big meta-analytic studies which is confirming that. After that, we moved on what type of analysis of electrocardiogram gives you the best result if you want to address that question. It asked to early detect whether a person who is showing the symptoms of depression already have cardiovascular risk, have that under medical attention, because it can be prevented that many people who are suffering from depression are actually dying of cardiovascular event, most of all myocardial infarction. What you can do? You can record that signal not only with standard machinery, which is present in every modern hospital, but also with many portable monitoring devices which are on the market, from smartwatches to devices that are actually giving you medical level of quality of signal. There are many devices on the market, so you can even use that to remotely monitor outpatient. Clearly, telehealth plus IoT and personalized medicine as its best. So, what you can read from that kind of recordings, for example, you can see whether a person has depression. Second, you can see whether a person who already has depression also has cardiovascular risks, meaning whether you can detect that the cardiodynamics is aberrated, which usually is the first sign that larger disruption of the system is on its way. There are some proven methodologies which can work here. For example, heart rate variability biofeedback, and many other ways of how a doctor, a clinician, can address that if he is working with a patient suffering from depression. Second, based on heart rate variability, especially in nonlinear analysis of that robust marker of cardiovascular disease and depression, you can say whether there is comorbidity, meaning whether the person who is suffering from depression also has anxiety, because in anxiety that connection is also very pronounced. Also, based on that, it is proven that you can say which subtype of disease a person have, whether it is melancholic or non-melancholic depression, which is shown since 2014, for example, in the work of Kemp and his colleagues. Also, based on electrocardiogram of the person who is suffering from depression, it is possible to detect suicide risk, and I'm wondering why no one is using it. For example, there are several papers that showed, since 2011, also 2016, 2017, that if you analyze electrocardiogram of a person who has depression, you can discover whether this is suicide risk based on parameters that can be extracted from that signal. So, to summarize, our question to clinicians is whether it is ethical to ignore what we as engineers and neuroscientists discovered that can be useful in clinical practice. So I'm aware that psychiatry is one of the most conservative fields in healthcare practice and medicine, of course, but that it is time to change. Thank you for listening.